All right, hi everybody. Thanks for having me. And I have the worst imposter syndrome right now beside these guys because I am not a unicorn. I'm a pure clinician. So I'll give our disclosures here. So this was done in conjunction with a group called Artemed out of Baltimore. And they actually optimized the AI risk stratification model and did the data analysis. So not me. I was hoping one of them would be here with me today to kind of help with the hard questions, but we'll work through it. I got involved because Mayo has a platform accelerate program where we give people access to our de-identified data and a specialist in the program who is me. So I'm the long COVID clinician who vetted their data. So that's the platform accelerate logo. I've done my due diligence for the Mayo. Um, all right. So the background. I don't have to tell this group that long COVID is a big problem, right? I mean, we wouldn't be here if it wasn't. This is the CDC graph from 2022 looking at prevalence of long COVID. 6.9% ever had it, about 23 million at that count, probably much more by now. And 3.4% were estimated to currently have it. And, we're going to run into funding problems because it's more common in women. That's a sad truth of most of the diseases I study. So, the background on this study was that the high demand for long COVID clinics led to incredible wait times. And back in 2022, 2023, when we're actually conceiving this, we're getting headlines like this, San Antonio clinics, months-long waiting lists, why aren't you taking care of us? People were really struggling to access care. And this was real, and we felt it. At that time, we looked at our wait list, and it was over 6 months. And between then and now, it's only gotten worse, right? I mean, we still have the same demand, but less long COVID clinics. In fact, we're the only one in the state of Minnesota right now. So the other thing that kind of came up around the same time is that we're finding that people with long COVID were really high utilizers of healthcare resources. And this paper, and it was by Dr. Tenney et al. In International Journal of Infectious Diseases. I'm going to blow up the part that's actually pertinent. It gets fuzzy, but if you look at the 12-month follow-up for people with long COVID versus those who were infected but didn't get long COVID, these are all PCR-confirmed cases. You can look at the cost per month before and after the PCR testing. In people with non-long COVID, it went from $1,600 to $1,700. Given inflation that year, that's probably inflation. In people with long COVID, it doubled from $2,000 a month to $4,000 a month. So that's actually a pretty high number that creates a problem that we need to solve. So the research question that we came up with at that time was, do long COVID clinics actually reduce healthcare utilization? There was one paper that had 238 long COVID, there weren't technically long COVID clinic patients. There were people who had long COVID, and the control group was people who had COVID and were discharged from the hospital, but not necessarily having long COVID. But even then, comparing the two groups, the big thing they found was that having access to a long COVID clinic was associated with a pretty significant reduction in healthcare utilization. So, the hypothesis of our question was, is early presentation to a long COVID clinic associated with decreased healthcare utilization? So, we took a look at our data and we decided to do a case control study. We started in March 2020, which was about the first time that people were using ICD-10 codes to denotate long COVID. And we went all the way to September 7th. And interesting to note here is that our first long COVID clinic started informally in April of 2020, formally in June of 2020, and the clinic I run started in February of 2021. So some of this data predates there actually being a long COVID clinic, but people could actually get into one within 6 months. We use diagnosis codes to identify people with long COVID. There's obviously a problem with that, in that people weren't diagnosing long COVID really early on, probably still aren't. We needed patients to have at least 6 months of clinical data to define the follow-up period, and they had to be more than 18 at the time of long COVID diagnosis. This is where I wish my data scientists were here with me, because they use this algorithm called fast, large scale, almost matching exactly. And we basically put people in two groups, those who got into a long COVID clinic early, within 6 months, and those who did not get into a long COVID clinic early. But let's start here because given that waiting times were 6 months, this really was almost a game of chance and a game of early diagnosis and access to healthcare. So there's definitely a confounder in that group. Looking at the chart, 7,000 people with a long COVID diagnosis, distilled it down to get those with 6 months, came down to 6,000. We wound up excluding people who got into a long COVID clinic, but after 6 months, that was only 50 patients, and that left us with a cohort of 6,300 or so pre-matching. We then matched to minimize confounders, demographics, comorbidities, vaccination. We made sure to match for timing of infection because we knew that long COVID looks different based on which variant you got hit by. And if you want, that's the comorbidities we looked at. I put it in fine print because I don't want to read it. So when we matched, exact matching got us about 2,800 patients. It wound up being a 1-to-3 match between those who got into a long COVID clinic early and those who didn't. We managed to get pretty close on female ratio as well as age. And I didn't put it on that slide, but vaccination status was pretty close as well. And then when we applied the flame algorithm, we managed to get down from 5,400 patients who didn't get in to 2122. That really matched closely to 692 in the long COVID clinics. Other thing we did is that we tried to use costs based on stuff in the literature from 2016. I do not trust this data, but it's what's out there because an outpatient visit and an ED visit have never cost me the same thing. I don't know about any of you. And the other thing to note is that, for the very same visit, the cost varies incredibly depending on what kind of insurance you have. So you can see Medicaid will cost you $300 versus cash price of $1,000. So it's not exactly a linear data trend. The other thing to note is 2016 to now, healthcare has gone up by 25% at the very minimum. So we have to bear it in mind when we think about this. All right, so what do we find out? I'm very, very happy that Dr. Upton talked about bootstrapping, because now I don't have to define it. But we did 1,000 iterations of bootstrapping to make sure that we didn't, wind up with the perfect scenario to give us either great results or turbo results. And here's a table of what we actually found. It's busy, so I actually put in a different slide. So when we looked at the average effect, we got that people who came to a long COVID clinic early had 0.6 less inpatient visits, 0.2 less emergency department visits. They saw the outpatients a lot more, 7.6 more outpatient visits. 4 of these were kind of planned with physical therapy, occupational therapy, etc. And costs went down by about 3,500 using very conservative 2016 numbers. I put this mortality trend in there not because I believe that long COVID clinics save lives, but that if you use big EHR data, you're going to get numbers that make absolutely no sense. But that was one of the things that came out. It was statistically significant, but I don't think that having access to a long COVID clinic actually saved lives. The other thing we did with this data is that we used the data to train a model to use the criteria from the chart to predict a diagnosis of long COVID. And then we trained that model to predict utilization greater than 2,500. And it actually got pretty good. So the area under curve is 0.84. It's not 1.0 like Dr. Fraser's curve from yesterday, which I've never seen before and don't think I'll ever see again. But it's pretty good. And we haven't figured out what we're going to do with this data yet. I'll talk about that model in the future directions here. So what did we actually find out? Well, we found that early usage of long COVID clinics is associated with lower utilization. Is this a factor of the long COVID clinics shifting the care from inpatient to outpatient and relieving that health anxiety and providing a pathway to manage all the symptoms, so that people aren't constantly having chest pain and palpitations and wondering, do I need to go in? Or is it the factor that the people who get into long COVID clinics earlier have more resources, diagnosed earlier, intrinsically more motivated? We don't know. But there is definitely an association here. What do we want to do with this data? Kind of want to start using these tools for long COVID identification as a diagnosis aid. I think that long COVID is underdiagnosed. If you look at the charts of the people who come to my clinic, incidentally, before they see me, it's fatigue, it's shortness of breath, it's all these symptoms, but not actually identified as long COVID. So we're probably missing a ton of people on our EHR chart review for just looking on diagnosis codes. And then I think that the other thing we can do is that since our model is starting to pick up the people who are at risk of high utilization, could we stratify those people to see a long COVID clinic and make better use of what is now a scarce resource? So that's kind of where we want to go with this. And I'd like to thank you and take any questions.